I just
Yes, the head is.
taking my cover. There's no time like to have someone. Like I just need to be researching. Like the different ones at FIU. But I did see a doctor there. He did email me back and he was asking why I thought the doctor didn't decide. When I graduated, so I sent him back, but he hasn't decided
That's everyone. In the middle, it's just that,
I gave a very professional response.
Coulter,
It was like I just wanted to explore the research and grow up.
well, the winner came first.
I know funny everything you have experienced by
In her life.
we just don't get the mentor or the lag.
It just depends whether
Sports, so I feel like kind of like familiar.
you're definitely not.
Hey, how are you? All right.
If you haven't already done so, sign in, grab a donut, coffee. We'll start in just about a minute or so.
Armand? Armand?
We got some project to do and we have another council meeting today.
I mean, we are.
All right, let's get started. Hopefully, folks will be able to find us down here. Sorry for the change in location. We kicked out of 2300. But welcome to our Heart Month lecture series. I am super excited. This is the 8th year that we have done this lecture series. It started with Dr. Ramaswamy and I 8 years ago. The idea was to bring in heart and vascular related folks for the month of February to give talks and to continue to help build our heart and vascular research here in Miami. I'll note that this is one of the signature events of this lecture series is our Heart Day Symposium, which is next week, February 14th. Just wanted to announce that lecture will be over on main campus in the Mark Building. It'll be an all-day symposium with poster sessions and outreach events, flash talks, so make sure you join us next week to become a really signature event for heart and vascular research in South Florida. For today, however, I can't think of a better way to start off our Heart Month than by welcoming Dr. Ajit Yoganathan from Georgia Tech, affectionately often known as Dr. Y to many of us. So Dr. Yoganathan is Emeritus Regents Professor and Wallace H. Coulter Distinguished Faculty Chair from Georgia Tech University. He is an internationally renowned pioneer in cardiovascular research. I cannot emphasize that enough. He's especially known for transforming our understanding of the function of heart valves and in congenital cardiovascular defects. His research efforts have bridged basic science and computational modeling and clinical practice. He's going to talk to us a lot about that today. And he's also passionate about engineering education and training future leaders in the field. As you can imagine, he has seminal publications, been well funded throughout his career, and received numerous awards in recognition of his contributions to our field. Notably, he received the Heart Valve Society's inaugural Lifetime Achievement Awards a few years ago. He was also a founding fellow of AIMBE, an honorary fellow of the American Association of Thoracic Surgery, and a fellow of both the American Society of Mechanical Engineers and the Biomedical Engineering Society. In 2015, he was elected to the National Academy of Engineering. And this is one of the highest honors that any engineer within the United States can receive. Today, he will teach us about his work in bridging his research to clinical impact, and it's sure to be a fantastic lecture, so please join me in welcoming Dr. Yoganathan.
Thank you, Josh, for that warm welcome. Good morning, everyone. It's nice to see bright faces rather than do seminars on Zoom that I've been doing for the last 3 to 4 years, but it's nice to be down here. As I was reminiscing, I've been down to Miami many times, but this is my first visit to the FIU campus. I visited the Coulter Foundation. Obviously, we have strong relationships, similar to what you have. We've been endowed by the Coulter Foundation since about 2001, 2002. And the chair I held before my retirement was for the Coulter chair. What I want to do in the next 45 minutes is to talk about some of the things that I've done. And when I say personal journey, I'm going to start back in around 1974 when I started graduate school at Caltech. So we're looking at a 50-year event, and I think I will stick to the heart valve. If I have time, I'll get into the area of the work that we've done on congenital or pediatric. The heart valve story, I think, maybe, well, is of interest to all of you, and also it ties in both what I call from the bench to the bedside. We're looking at things that go from the development of a device that's life-saving into implants in patients to save their lives. So the field of biomedical engineering really didn't exist to any extent. I think Johns Hopkins may have had biomedical engineering when I started. I didn't even know it was something. My background is all in chemical engineering, both at undergraduate and PhD level. And my initial faculty appointment at Georgia Tech for 20 years was in chemical engineering. Biomedical engineering as a department didn't start at Georgia Tech until 1998. So I use this slide as talking about how when getting into a field that one wasn't planning to. When I first went to Caltech and found out about some of the blood flow research that was going on by one of the faculty members in chemical engineering. And from that area, I got into looking at blood flow in arteries, and from that to artificial heart valves. So I think the moral of the story is that sometimes there are opportunities that come by that one ought to take advantage of, and that gives you a completely different outlook on life and gives you a lot we're talking about the heart valves in the heart, left side, two valves, the aortic valve, the mitral valve, and on the right side, the pulmonary valve and tricuspid valve. These are all one-way check valves that allow blood to flow in a single direction from the left heart through this arterial system, oxygenation, and then returning to the right side, back into the right heart, and then flowing into the lungs. So oxygenating the deoxygenated blood. What I'm going to focus on is the aortic valve today, because it is the valve that sees the most amount of disease. And if you look at the statistic, there are a variety of ways these valves are diseased. When the valve is not functioning properly, we have two conditions, one called stenosis and the other called incompetence. In other words, with stenosis, blood is obstructed in flowing in an unobstructed manner, and when the valve doesn't close properly, blood leaks backwards. Either of these conditions reduces the efficiency of the heart and leads to the need for either valve repair or replacement. We do not have any medical therapies at the current time to treat valvular heart disease or any of the valves. So they need either surgical or cardiac intervention to repair or replace them. Because if that's not done after a certain stage, the patient will ultimately succumb to their life because, again, it would overload the heart and you run into heart failure. There are many causes of valvular heart disease. Worldwide, rheumatic fever is the major cause. There are 30 million people out there, as data from the World Health Organization, that have rheumatic fever, and that leads to rheumatic heart disease. And that's mainly in countries, in developing countries, Africa, certain Southeast Asia, the Middle East. Rheumatic fever is not of a big issue in the United States or in Western Europe. The major cause of valvular heart disease in the United States is degeneration of the tissue for a variety of reasons. Old age being one of them today. Calcification is a major cause of aortic valve disease in the elderly population in the United States. There is 1 in every 100 children born in the United States has some kind of abnormality in the heart, and 25 to 30% of those have an abnormal heart valve. Those numbers may seem small, but that leads to about 250,000 children being born every year in the United States with a malformed heart valve in one of the 4 positions. Bacterial infection is another cause. Injection of drugs it leads to using bad needles, leads to bacteria that cause valvular heart disease. So these are the main causes, but again, it is what causes defects in the valve. Here's some pictures showing this. Calcification. Endocarditis is a bacterial infection which occurs in small number, but it's extremely deadly. If you get endocarditis, your chance of survival is less than 5%. So it is a very small number of people who get infected by bacterial infection, but it is deadly. We also have bicuspid aortic valves. The normal aortic valve is tricuspid. A number of people are born with a bicuspid valve, and in many cases that leads to calcification as the person grows. In mitral valve, a lot of the diseases are tissue-related and are related to the valve biology. Again, and there's also in the elastic composition of the valve leaflets, a lot of changes occur. I just want to emphasize again the understanding of the biology of valvular heart disease, whether it's aortic or mitral, is still in its infancy in terms of understanding, and that's what has led to the lack of availability of any kind of medical therapy for valvular heart disease. So if you look at the overall effect, 2.5% of the overall US population has some type of valvular heart disease. And as these graphs indicate, from age 65 onwards, that number increases very rapidly. This slide is from 2006, but these trends still hold very much so. And knowing that the population in the United States is aging, the numbers are increasing. So even if the percentage may stay same, the number of elderly people affected. And these numbers also reflect similarly worldwide in Western Europe and Japan, Canada, Australia. And as you can see, the rise in the disease progression, especially in the aortic, is quite distinct, and then as well as in the mitral. So if you break down the statistics for aortic valve disease, above age 75, it's 3.4% that have aortic stenosis, about 2% have a leaking aortic valve. So the number of people in the unit is about 500,000 people every year in the United States are eligible for some kind of valve replacement or valve repair surgery. Approximately 1.5 worldwide. I think that's an underestimation because again, many people go undetected by their clinicians. In the United States, there's about 100,000 to 125, these numbers are a little bit on the low side, and about 350 to 400,000 worldwide. But the estimated number worldwide is over 2 million people could benefit from valvular heart surgery or valve replacement or repair on a yearly basis. So the numbers we're looking at are quite dramatic, and it's sort of an area that people don't talk about much about valvular heart disease. Everyone is talking about coronary artery disease, having a heart attack, but this is the second leading cause of heart. And it also, like I said, if it's untreated, the long-term consequences are you going to heart failure and the heart just stops pumping. One of the first people to talk about the aortic valve and also the mitral valve is Leonardo da Vinci. If you go to the British Museum in London, you will see the sketch of his sketch of the aortic valve, and he was one of the first people to sketch what the three leaflets look like and flow in the sinuses of Valsalva. These were based on what he visualized from cadaver. Even though we consider him to be an artist, he was really a very multifaceted human being. He was an artist, a sculptor, a painter, an engineer, a physiologist, and he cut open human bodies. He looked at the anatomy. He has, if you look at, there's a book where he has sketched out muscle from valves to the heart, to muscles, to bones, the nervous system, based on his observations. And then he also did a lot of animal experiments as well, in terms of cutting open animals and seeing the structure. So if we again come back to the normal aortic valve, it's a three-leaflet valve, relatively symmetric, and the three sinuses are where from which two of them, the coronary arteries come. These are the main highways. The coronary arteries are what carry blood from the heart muscles. Below is shown here the disease or calcified three-leaflet aortic valve, and on the right, bottom right here is a bicuspid aortic valve that is calcified. So as I said, there is no treatment for medical treatment. So the alternative is devices. And this is a slide from 1955 that a slide from the American Heart Association talking about the initial development of artificial heart valves that started around in the mid-50s, early to mid-50s, and what is shown here is a ball and cage valve was developed based on a patent from the early 1900s or late 1800s for a stopper for soda bottles to hold the carbonation. So like you have carbonation in Coke cans, soda, tonic water, or any other carbonated drink, you've got to hold the pressure, the air pressure in there, or gas pressure, and there was a patent on that. And this was developed based on this patent by an engineer, aerospace engineer out in Seattle, Lowell Edwards, together with the surgeon Al Starr, who was in Portland, Oregon. They created the first artificial heart valve, which was the style was ball valve. And that's what is a diagram slide showing the development. Even though these valves were initially developed in the mid-1950s, the first implant of a heart valve in what we call the orthotopic position, i.e. in the position it's supposed to be in the heart, wasn't until 1960, and that was because there was the heart-lung machine, or the machine to do open heart surgery and take a patient off the natural heart and bypass flow, hadn't been developed in about 1959. So the first series of heart valves was started to be implanted in 1960, and we have gone through a whole series, and this is pictorial, of different mechanical heart valves and biological valves, which we'll talk about more. And today, we see that also shown here are different timelines for their approval. And in 1976, there was the Food and Drug Administration, the FDA, was given authority to regulate the development of these devices. So until 1976, someone could develop a heart valve, test it in their garage, and go implant it in the patient, and that's exactly what happened. Since 1976, the Devices Act was passed that gave the FDA authority over medical devices. I mean, heart valves is one of the major ones, but that includes starting from a bedpan to a hospital bed, which are considered medical devices, to heart valves. To expand on that, here's pictures showing sort of the major valves that have developed over the years. The Steinway's ball valve was one of them. There were other different types of ball valves with this. Then came the tilt-in disc valve, the Yorkshire valve. And the materials changed. This was silicone rubber, pyrolytic carbon, titanium. Also, there were cage disc valves. This was a polypropylene type disc. A different type of tilt-in disc valve, the Medtronic Hall, and in the late 70s came the bileaflet valves. And if you look at these from an engineering point of view, you can see we went from what one would consider inefficiently or designed, or at least conceptually, valves that would not be very efficient for flow, because as you can see, this ball would obstruct flow going through it and make flow to go around it, to what we would call more centralized flow here with these bileaflet designs. And bileaflet valve, it's made out of, all made out of pyrolytic carbon and pyrolytic carbon. Of these mechanical valves, today in the United States and Western Europe, this is the only design that exists, the bileaflet design. The St. Jude valve that was first designed around about 76 to 78 has over 3 million of these implanted worldwide. So it gives you a set number of valves that are implanted, and these are all implanted surgically. In other words, you require open heart surgery, and the valve is sewn in on this sewing cup into the position of the heart. In order to look at alternatives, surgeons played around for many years, even starting in the 60s, trying to use natural tissue from the body itself But what came out in terms of commercially usable tissue are porcine, that is actually taking the porcine, the aortic valve from the pig heart. The anatomy of the pig aortic valve is fairly similar to the human aortic valve in terms of size and geometrical structure. Taking that out and mounting it on a stent, man-made stent. The tissue is totally inert, so it's not living tissue because it's fixed in glutaldehyde, and one has to do that, otherwise you get biological materials, the prions, etc., that are transferred from the pig to the human, which would then cause significant rejection problems and other infections, and other diseases. So the valve is fixed in glutaldehyde, where the tissue is now totally inert. It becomes like shoe leather. The other material that's commonly used today is the pericardium, and that's taken from the calf. The pericardium is the outer sac that we have. We have human pericardium, it's the outer sac of the heart. Similarly, we have that in the calf or any other animal. The pericardial leaflets are made from the tissue of the pericardium of the calf, again fixed in glutaldehyde to do inert, make it inert. Now, there have been and there are still cases where you can use the patient's own pericardium to create a valve in the operating room. That's very time intensive and challenging. Places that is done is in very complex congenital abnormalities. A pediatric surgeon will do that, and due to a variety of reasons, to give a better outcome for the child. So we've had 6 to 7 decades of valves being developed, but unfortunately, we still have a number of problems. We don't have the ideal valve. We don't have a valve that will last the lifetime of the patient. We don't have valves that don't have complications. So the biggest problem we have with mechanical valves, even though from a mechanical point of view, the valve is designed to last 50 to 100 years. In other words, it's not going to break. And that's from a structural point of view. The biggest problem we have is the issue of thrombosis and thromboembolism. In other words, there are different mechanisms due to using foreign material and the flow fields that we create. Activation of the platelets, damage to the red cells, damage to the platelets that creates thrombosis and thrombus. In other words, we create blood clots. Because of that, patients who have mechanical heart valves have to take a blood thinner. They have to take lifelong anticoagulation therapy. They have to take a tablet once or twice a day for the rest of their lives. So that is and what that does on the negative side is those patients have increased risk for bleeding. So it's the balance that we have in homeostasis of our system. In normal, we have a good balance in terms of anticoagulation in our own bloodstream versus bleeding phenomena. So that is the biggest challenge with mechanical heart valves today, and it has been there from day one for us. In terms of the prosthetic valves, the biggest issue is calcification. Like the native valve calcifies, we get calcification on the biological tissue, but it is not the same mechanism. It's an extrinsic calcification having to do with the glutaldehyde treatment and the fixed tissue. While in the native valve, it is more intrinsic calcification. And because of that, the tissue fails. And the failure is anywhere from within 5 to 15 years. So on the one side, we have a mechanical valve that's designed like to last 50 to 100 years. These tissue valves break down no matter what within a 5 to 15 year time period. So we are dealing now with patients who have to either decide to have anticoagulation or versus having to take a valve that needs to be replaced in a 10 to 15 year lifetime. This shows some of the issues that we face with mechanical valves. In the earlier ones, we did have valves that were mechanically or not designed properly, or had manufacturing defects that led to failure. And this shows a Yorkshire valve where the strut broke. And in the case of a mechanical valve, if there is mechanical failure, unfortunately, tends to be in most cases catastrophic. The patient will not, unless the patient gets to an emergency room pretty much immediately, the chances of survival are minimal. So mechanical failure with a heart valve is not an option that you have. It's pretty much life-threatening. It is different from having a knee implant, and when the knee implant fails, you're not going to die. Okay, you may fall down, you may be immobile for a few days till it's replaced, but with a mechanical heart valve, if there's structural failure, it could pretty much lead to immediate death. On the bottom here is shown the issues of thrombosis, blood clots forming, and leading to essentially malfunction of the valve. This shows the porcine valve that's calcified and not allowing leaflets to open. You can see the calcium nodule. You can even see a tear in the leaflet. So if you look at complications, we have thromboembolism, leaflet calcification. Those are the two main issues. And many of these are related to some of the flow characteristics of these valves. They're not all, but they have a relationship to the flow. And we come back then to the famous workhouse triad from the Austrian physiologist who proposed in the 1800s the understanding of blood and its phenomena in flowing through the cardiovascular system. It's the triangle. We have blood, the characteristics of blood flow. If you have flow stasis or flow turbulence. On the other hand, it could be an artificial surface or a damaged wall of a vessel, and the coagulability of the blood cell activation, the blood coagulation characteristics of a given patient. And that's very important. That's where the individual issues come in. That in some patients, they may need less anticoagulation, while some other patients need more anticoagulation, and that is defined to a large extent by the individual nature of the coagulability of the blood of a given patient. This slide here shows from article in 1976 by a pathologist by the name of Bill Roberts, who showed that his visual understanding, and this is before today we have ultrasound, MRI for visualizing blood flow in the human heart, on the bench, in animal models, but this was what he envisioned blood flow would look like based on the characteristics of heart valves that were being used there. And he quite accurately depicted this, showing that with the ball and cage and disc valves, flow was abnormal. While with the native valve, you have unobstructed flow. With the porcine valve, he showed it to be, the flow to be a bit narrow because there the tissue leaflets don't open out all the way, and there's also a man-made stent in which the valve is held. So in this article, he talked about the normal flow characteristics that would happen. And as a pathologist, he was examining valves explanted from patients who had passed away or had to have a reoperation to see the consequences of that. Over the years, we have worked and developed many flow techniques, so looking at things starting from very simple flow visualization to optical techniques, laser Doppler velocimetry, particle image velocimetry, in 2D, today 3D, and now clinically since the 90s, mid-90s, we've had color Doppler imaging, ultrasound imaging, we've had magnetic resonance imaging, where we can look at flows, and then more recently using computational fluid dynamics to look at flow structures. So if you look at mechanical heart valves, the rate of thromboembolic complications is on the order of 1 to 5% per year in that patient population. And I just showed you an example of where areas of thrombus form on these valves. As you'll see, these are areas of normally low flow or high shear stress, where damaged platelets will activate the deposits and create blood clots. This is some early work that we did in the mid-70s using the Bjorkshire valve, which at that time was the most commonly used mechanical heart valve. And this is a very simple experiment in steady flow. I won't go into the details of the setup, but it was a steady flow setup looking at flow above and below the disc. So as you can see, there are two areas for flow above the disc being more, less. And then when you look close to the disc, on the underside of the disc, there's a large area of flow stasis, which will not get washed out. Now this is a static experiment in that this valve will open and close in a beating heart. But as a first approximation, when we were doing these studies, this was the best we could do at that time. Today, this experiment would be considered pretty worthless. But what it shows is you can gain insights from simple experiments. And they do give you an idea that that area, if it doesn't get washed out, could be a potential area for clot. And that's what was seen. We were working at that time with a major center in Southern California, which had a lot of valve implants, and they were seeing valves coming out of these patients that had clots. So that was clearly a causal relationship that so if you could get better washout on the underside of that valve, you have less opportunities for clot formation. Let's go down to the bileaflet mechanical heart valve. Like I said, today actually this number is more than 3 million of these have been implanted worldwide. This is the most commonly used mechanical heart valve. And worldwide today, approximately 50% of valves are mechanical, 50% are biological. So they're durable, they have relatively good forward flow characteristics. But what I want you to do is focus on this area of the hinge where the leaflets open and close. And these are three different designs of valves that have been used clinically. St. Jude Medical, which is the most commonly used valve, mechanical bileaflet valve today, and has been around since 76, 77. And you can see the geometry of the hinge, and again, you need to look inside the hinge. The second is the carbometics, and then the Medtronic parallel valve, which I will show as an example of design that failed in its early clinical use. So if you look at it from a fluid mechanics point of view, you're looking today, we would call this, you're looking at large scale features in the bulk of the flow, which are on the scale of about 10 millimeters. And you're looking downstream of the valve. Here you're looking inside the hinge. And this is a clear bottle machine to look inside the hinge. Because remember, these are paralytic carbon valves, so you can't actually see them unless you create a clear model. And the length scale there is 100 microns. So you're looking at three orders of magnitude difference in the flow field characteristic. And in fluid mechanics, that's quite challenging. That's a multi-scale problem that you're looking at. And whether you're looking at it experimentally or computationally. So if you're looking at the bulk flow, you experimentally, we would use techniques like laser Doppler or particle image velocimetry, while for bulk flow you would use particle image velocimetry, and for CFD you would use a large scale CFD solver. To look inside the hinge, which is on the order of in the 100 micron size, you would use again either microscopic particle image velocimetry or laser Doppler. Sorry. Or you would have to use a microscale CFD solver. Very challenging problems even today as we try to understand the flows of these. In terms of the large scale, as you can see here using PIV or flow visualization, you can see flow is, even though it is coming out nicely through the two leaflets, it is disturbed, it is turbulent. This shows the velocity field, and this shows the vorticity or the swirling nature of the flow field characteristics. So even though this gives you nice forward flow overall, it is still not as good as one would have with the natural aortic valve. This shows some CFD work using the lattice Boltzmann technique, work that we did in around about 2014, 2015, and you can see that we can simulate the flow field very well. Unfortunately, these simulations are done on high performance clusters and extremely time consuming. These simulations would take 2 to 3 weeks to do at that time. Even today, these would take at least a week in terms of simulation. To look at the hinge flow field, we had to develop clear models. Initially, those had to be machined. This was in the late 90s. There was no 3D printing. There was no micro CT. These were created by the company St. Jude for us to do some work so they could provide this information to the FDA. So they built these. We didn't have their machine drawings. They had the machine drawings. They had these machined, very time consuming to create one of these models at that time. And then from these clear plastic models, we could look at flow through the hinge using laser Doppler velocity. And this allows us to look at flows through them. And I want to show one example where this type of analysis led to looking at the failure of a given valve. This was the Medtronic parallel valve that was designed in the early 90s and used, and in its clinical trial, it failed in that 13 out of the first 60 patients who received this valve developed thrombus within the hinge. The studies on the bench didn't show any problems, because at that time, no studies had ever been done inside a hinge. But then the company made these geometries and allowed us to look inside the hinge. And what we saw was the washout in the hinge area was very poor. And this is a valve that was explanted from a patient who passed away with this valve, and you can see that the hinge here is built up with thrombus. Since that point of time, one of the tests that are required by the FDA for studying these kinds of valves is looking at the hinge area to look that there is adequate washout. Since then, we've also developed methods of CFD for looking inside the hinge and looking at washout. So today, you can use a variety of tools, experimental and computational, and use them in combination to assess areas that have potentially can create problems with thrombus deposition with mechanical heart valves. If you look at biological valves, there have been a whole series of them that have evolved since the 70s. We show the more commonly used pericardial valves made by Edwards Life Sciences in California, Sorin Biomedical in Italy, and then there are some porcine valves, mainly the Medtronic valves that are used. And these are all mounted on a stent. The tissue is mounted and implanted. There have been valves that have been created without a stent and allow the surgeon to sew it in. These take more time for the surgeon, and therefore more time on the bypass, and therefore, and it also takes more skill level on the part of the surgeon to implant the stentless valve, and therefore they're not as commonly used as these stented valves. To give you an idea of how these valves function, this is looking right down the barrel of the valve in a flow simulator. You can see opening and closing, and you can see that the leaflets, some leaflets open, one of the leaflets opens faster than the other. Some have more stresses on them, and it is not a clean, wide opening area. This is the pericardial valve, and these valves tend to open more symmetrically because one is cutting the leaflets from a flat piece of tissue, sheet of tissue. You can match them more compared to the porcine valve. Because the porcine valve is coming out of the pig's heart, so you get what you get. You don't have much opportunity to changes and the geometric configuration. Even with these valves, when you look at them in a flow simulator, as you can see here, there are areas of stasis and not as good washout. You have nice central flow on the side, but behind the pockets of the leaflets, you have areas of low flow. This is showing now more quantitative measurements using PIV. And again, you can look at different characteristics around the valve. You can look at the effect of the cardiac output, that is the rate at which blood is being pumped. This is sort of a resting condition. This is with someone who's more in heart failure, who has a lower cardiac output. And you can see the areas of stasis increase when you go to lower cardiac outputs. So until around 2000, all valves that were implanted were all surgical. So in other words, you had to undergo open heart bypass surgery, which meant that you went to the hospital, you had your surgery, you were in the hospital for 7 days, 5 to 7 days before you came out. And as you know, there are complications by having to bypass blood through an oxygenated system. Blood gets damaged, you have other issues that come out, and it's a very stressful. And not every patient is fit for having open heart surgery because they may have other comorbidities. They may be diabetic, they may have kidney failure. And about 20 to 30% of patients who have aortic valve disease are not eligible for open heart surgery. They're considered high risk or essentially cannot be operated. Surgery will not open because they know that that patient will die on the table. So why even start a surgery? So because of that, for this high risk inoperable patient, as you know, since the mid-70s, coronary artery stents have been developed to be delivered on a catheter. One of the first developments, I guess, finding out that this building belonged to Cordis, which was the company that was developing stents for different applications instead of coronaries as well, instead of bypass surgery. That was, could you put a valve on a stent or a valve on a stick? And a cardiologist in France in 2002, Dr. Alain Cribier, developed a valve that could be put on a stent, and he implanted it on an 80-plus-year-old French lady who had no other option, and she survived. That was the start of the development of percutaneous valves. What I show here are the two most commonly used valves today, the Edward Sapien and the Medtronic Core valve. These started being tried clinically in the United States around 2010. So again, between 2002 and 2010, there was a lot of development in industry. And these are valves, very different characteristics. The Edward Sapien valve is on a balloon expandable stent. It's a cobalt chromium stainless steel. So you crunch this down and you expand it with the balloon like you do with a stent in the coronary arteries. The tissue is bovine pericardium, the calf pericardium that was used in surgical valves. The Medtronic core valve is a self-expandable stent. In other words, we have materials that have memory, nitinol, put it down, and when it opens up, it goes back to its original shape. It doesn't need any balloon to expand it. And you can then put thinner material on, tissue on it, and the porcine pericardium, which is now the pericardium from the pig, pericardial sac. It's thinner by about a millimeter compared to the bovine pericardium, and it's put on this. So the different materials here, very important in terms of functionality. And this is how, this is the animation from both these valves, as you can see, different. It's a catheter that you bring up normally through your femoral artery, the leg artery, but it's the same way that they deliver a coronary stent. You come in and you balloon out the calcified aortic valve. So the big difference here between a surgically implanted valve and one is it's on a beating heart. So it has to be delivered in a catheter. The only way you can visually see this is by some imaging tool, either fluoroscopy, ultrasound, such. So you are looking at something, and unlike a surgically implanted valve, where the surgeon will go and remove the native tissue, all the calcified tissue, and has the ability to feel, touch, and see, you are now deploying a valve in the existing calcified native valve, ballooning it out, and doing everything with your hands and looking at a screen. Very different characteristics, very different ways of these being implanted. In the 10, 15 years now we've had this, there's been significant, there have been 3 generations of these valves in both companies. There are other valves that are in place. So there has been a lot of technological change quite rapidly. And you can just see the numbers have changed significantly between the start of 2012, when 32,000 valves were being implanted, to today. It's projected to be 300,000 valves being implanted daily. We still, unfortunately, continue to have problems with these valves. These valves still deposit because of the stent material that is foreign. We activate platelets, we get deposition in areas, and thrombosis is the biggest problem. So even though you remove the risk of open heart surgery, we run into the issue. And there have been studies now with high fidelity imaging modalities, like rapid CT scanning, where we can see these phenomena. You can see that the leaflets don't move properly, they're deposited with material, thickening of the leaflets within, as early as within 6 months. And this has led to a rate somewhere between 20 to 30% of these valves can thrombose over a period of time. And the pocket in which they thrombose is this neosinus region. And this is a challenge because it's an area that doesn't exist with the native, with the surgical valve, because you have removed the human valve. This is forming in the area between the human valve that has been ballooned out and the tissue of the transcatheter valve. In order to look at that, we developed around about 2017 a model system shown here that allowed us to optically look at things and look at different designs. And with very high-speed PIV, we're able to look inside this pocket, imaging at the rate where we could look at flow every 5 to 10 milliseconds to look at the washout in this pocket area for different designs. And what we found was if we looked at those measurements and then simulated washout in that pocket region, you could see the varying regions of, for various designs. This was what we call a 0 deployment, a 5mm deployment, and compared to a surgical valve, these mimic conditions between the sapien valve and the core valve. You can see that the washout is very different. And this kind of analysis now allows us to look at how the geometry of this valve, when it's implanted in the human anatomy, how it varies. These studies were idealized. The question is, can we predict for a given patient, if a valve is implanted in them, what kind of flow characteristics? And people are developing tools for that computation as a predictive tool And in the future, maybe you have an AI model that you can implant this valve for a given patient based on their CT scan anatomy. You implant it virtually, it's going to his opportunity. Let me just show you where that goes. We took 7 patients initially for which we had their CT scans post-operatively. We created a 3D printout of the anatomy. Today that's very easy to do. You can do it with relatively optically clear material, or you can just create that, and then we injected dye into that pocket area, and we looked at the washout of the pocket. In all 3 pockets, 3 leaflets, you can quantify from this from this curve of the dye washout. And then we correlated that to the amount of thrombus or deposition of material that we could analyze from their CT scan. And what we saw was patients that had less washout in the pockets tended to have more thrombus. So more flow stresses and more thrombus in the implanted cavity. We broadened that. We looked at 27 patients with different designs. And again, we saw a very strong correlation between washout in that pocket. And the size of that pocket depends on how that valve is placed within the patient's native anatomy. A couple of things again to keep in mind, you're doing all this visually with your hands. You don't have the luxury with the open heart where you can go and put something in, look at things. And with the catheter you develop, and once you've deployed it, there's no taking it out. You are where you are. It's like when you land on the moon. When they come down, you decided where you're going to land on the moon, and then you can't change it. Once you landed, you're stuck there. So what this shows is there are opportunities here for looking at how the patient's anatomy to the given device looks like. You can do some simulations and look at potential outcomes. So just to finish up, even 7 decades later, today all prosthetic heart valves, whether it be surgical or transcatheter, create non-idealized flow. They don't create the flows that we have with the normally functional aortic valve. Areas of stasis, areas of high shear stress, using foreign materials, and blood normally doesn't like to see foreign material. It's one way of rejecting the human system, foreign material, so it does activate the coagulation system. So we need well-designed engineering studies, whether it be experimental, computational, combination, together with also blood studies to look at things. And this has to go into the design and analysis of these life-saving devices. If we stick to bioprosthetic heart valves, the tissue, whether it be surgical or transcatheter, we're not going to get a tissue that lasts more than 15 years, unfortunately. So how many of these valves do you want to implant? So there's much need for research in newer materials, tissue-engineered materials, polymeric materials, combination for valves that could last long. Keeping in mind, some people who need artificial heart valve are people as young as your age. Okay, even if you're not born with an abnormal valve, there are people worldwide who, due to rheumatic heart disease, have developed valvular heart disease, and is 15, 18 years old, need a valve. Versus the older population. So someone who's 75, 80, yes, one of these valves that lasts 15 years is fine. For a 25-year-old, that's not a good solution. We need a valve that will last 50 years. And that doesn't exist in the biological world, mechanical valve world. So that's the dilemma we face today in terms of how do you choose lifetime management for a patient. A mechanical valve that will last 50 years, but lifetime anticoagulation therapy, and possibly thromboembolic complications, stroke, etc. So again, a lot of opportunities for technological development. And obviously, hopefully, in the next couple of at least in the next decade, maybe a better understanding of why we have valvular heart disease and medical treatment. But again, the biology of valvular heart disease is very complex. There's no one disease, it's multifactorial. And so with that, I'll stop. A lot of this work, like I said, has been done over the last 40 years by a bunch of PhD students and in collaboration with many cardiologists and cardiac surgeons worldwide. Thank you very much.
A couple questions, if anyone has any.
That was an awesome talk. Thank you for that overall view of what has happened over the last 50 years in the world of aortic valve replacement. I was wondering, in your flow duplicator studies, your velocity profiles, even in like native porcine aortic valve, which is, mimics very well what's happening in the human valve, you still saw a lot of stasis in the sinuses. Does that mean that the native aortic valve is not the optimal valve that we could have? Like, and if you were to,
So
go back to our ancestors and be like, hey, if you're going to evolve this valve instead, which valve would you?
No. So what with the porcine valves, because of the stents, the flow around it is altered, and it doesn't take advantage. And they're not designed to take advantage of your sinus geometry. So if you go and look at the drawings that Leonardo did, and you look at, and actually today with MRI, we can put you in the MRI machine and look at the flow. What you will see is your leaflets, your aortic valve leaflets, match geometrically to your sinus geometry, and therefore you get a good washout. So there is that. So that's why we say maybe you have to select the valve size and geometry to fit the patient's anatomy, and that's what we don't do. I mean, we just stick. What they do is they look at the size of the annulus. That's where the surgeon normally slows it in. Says, okay, that's 25 millimeters. I'll take a valve that is 25 millimeters, and that's the only anatomic feature that they size to put a valve in. What we miss out is the fact, how tall is the valve? Does it fit within that geometry? And today with computational models, even simple computational models, we can show that you make this too tall, you won't get as good washout. So that's why anatomy becomes king in a lot of cases, because that dictates how that anatomy interacts with the blood flow.
And you limited your ability of the TAVRs. It's becoming more fashionable to do TAVR and TAVR and maybe a TAVR. That's going to compound this issue too, right?
Well, it's like you see those Russian dolls, right? How many dolls can you fit in? Okay, so you go from a hole that is this big, next one becomes this big, and then you go to a stent. No, you can't. There are patients who've had 2. I know some who've had 3, but that's just not feasible. And that's why people are looking at now understanding doing that initial implant is critical. If you can give that initial implant a 50-year runway, then the next one. And the other day I met a patient earlier this week actually, because of some childhood other problems she had. She was not a candidate for open heart surgery. So age 50, she had a calopidem, and today, 10 years later, that valve's failing. So at 60, she's going to have one. If the next one fails at 70 or 75, we don't know. And not what we actually think is that you put a tower in tower, that second tower is not going to last as long because the mechanical characteristics are very different. So it's a challenge. And what we are learning today is the word lifetime management. How do you think about managing someone over a period of time?
Final question? Yeah.
With some of the percutaneous heart valves, you mentioned that with some of the stents, there's cobalt chromium in combination with stainless steel.
Well, it is cobalt chromium.
Is there not a concern from the FDA that like some of the wear particles from the cobalt chromium other prosthesis?
So, very good question, that's an excellent question. So, in that ball and cage valve I showed you initially, the one from that, that's pretty much cobalt chromium. Now, obviously it's nicely polished, they're not putting in a candle, putting in there. With these, they are polished and they have, one of the tests that is required by FDA is particulate, the particulate count that you're supposed to do on the bench and see, because you're right, if you have a lot of particulates, then you're going to have problems. But that has not been a problem with the cobalt chromium that I use in the labs. But any design, and actually it is to the extent that what size French catheter you use, how much is Frenching down, and then when you put it right, how much you do. So that is an odd thing that you have to keep in mind very carefully, that you don't create particle debris in your community. Chances are, especially in the aortic position, that debris will take off and go the carotid artery and go to your brain, and create stroke.
All right, with that, let's thank Dr. Y again. And I look forward to seeing you all this week on May campus.